Welcome to this most recent episode of the Accad and Koka report. We are lucky enough to have Dr. Daniel Choi on the program today. Dr. Choi is a board-certified orthopedic surgeon. He has a special focus in minimally invasive spine surgery. He has completed neurosurgical orthopedic spine surgery fellowships at none other than Harvard. And now he's in private practice in New York City. And I got to know of Daniel because of all the work and the advocacy that he's been doing surrounding surprise billing. So Daniel, how did you get interested in, how did you get interested in surprise billing?
So interestingly enough, it was actually, and Anish, thank you so much for the opportunity to be in your podcast. It's excellent work that you're doing with the podcast. So happy to talk to you about this advocacy work. And surprise billing legislation, it's not a very sexy sounding topic, right? It's not reform. It's not any of these things that doctors usually get riled up about, SGR or whatnot. But it's almost a misnomer because this whole surprise billing thing, it was actually just recently in July, there were two bills that were passed out of committee in Congress. And it was actually a surprise, pun intended, to doctors that these laws were being passed out of committee. And just to give a little background on surprise bills, it's been an issue for the last 10 years, really. And what's been happening is that, patients have reported to NPR and various media outlets that they've been getting these big bills right after they end up in the ER and they get a laceration and they get it sutured up and it's a simple thing and they come home and there's a bill in thousands of dollars because their insurance, maybe the premium is the deductible is very high or whatnot, or there is an out-of-network provider at a certain hospital. And so maybe that hospital had an anesthesiologist that didn't participate in that patient's insurance network, and they got an out-of-network bill. And that's usually, those insurance plans have a cost-sharing clause to it. So they're responsible for 20% of an out-of-network physician's charges, and that ends up being a large sum. And so that's what's considered surprise bills. And it's been an issue. I am out of network with certain plans. I'm in network with some plans, and it is something that I think about as a practicing physician. It's part of the patient experience. They come here, they want to get their surgery, and then all of a sudden they get hit with a bill that they're not expecting. So it is an issue. And and doctors as a whole do believe that surprise billing needs to be fixed or ended, because there's been a lot of high-profile articles in the New York Times as well as NPR where patients are really being hurt by these surprise bills. And so various states across the country have actually taken up this issue with surprise billing. And New York was one of the first states to do that back in 2014. And they passed a comprehensive surprise bill law that took patients out of the middle. So if there was a surprise bill out of the ER and the doctor was out of network, the patient was held harmless. So there was no responsibility to the patient, which is what all doctors really want. And what it became was a arbitration process between the doctor and the insurance company. And so the two would basically arbitrate it out. And there's an independent dispute resolution process here in New York that was actually novel. No other state had it in place. No other state had tackled it like this. And it worked here in New York. And so after 4 years of data came out of actually Governor Cuomo's office, and it showed that this surprise billing legislation had actually dropped complaints. Patient complaints had dropped completely. In addition, billing, ER charges had actually gone down, and balance billing had gone down dramatically after this. Plus, on top of it, everyone thought that arbitration or this IDR, the independent dispute resolution, would be a horrible thing full of bureaucracy, and it would take forever to work out the bills. But no, the way that it's done in New York is it's 30 days and $300. It's a very simple process, and it's been awesome. I mean, the insurers won't admit it publicly, but they've also kind of privately said this works for us here in New York and it's working out. And so that's how New York solved it about 5 years ago. Now, interestingly enough, federally, this has finally come to the federal level. So different states have taken it up. California's taken it up. Texas has taken it up. Florida's taken it up. Everyone's kind of come up with their own solution.
Right. So I'll just stop. So it's important how you're casting it. For doctors who are doing this, who are working or in the trenches, it's pretty obvious to us that this isn't really about patients. This is really a battle, a negotiation that is constantly going on between providers of healthcare, doctors, and the folks who generally in the United States in 2019 pay for it, which is insurers.
Yep.
And that's exactly how you're casting it. Unfortunately, that is not how it's portrayed in the media, right? In the media, it's primarily portrayed as doctors fleecing patients. So before, of course, the issue here is that, a patient comes, as you said, a patient comes to the ER. Usually these are ER generated bills because it's not elective. And they have some urgent issues. Say they have a neurosurgical issue. They get taken care of by an out-and-out physician. And like you're saying, they get some massive bill. And that massive bill, of course, isn't negotiated down. There's no negotiated rate. So there's no discount. And the patients, who may make $60,000 a year have a $250,000 bill. It's an incredibly disconcerting thing to find. And again, as you're saying, this is really something that's between the insurer and the physicians, who basically didn't come to a agreement on what was a fair charge to stay in network. And the only thing the physician and the group can do to say, well, if you're gonna say that and we can't come to terms, we can't come to terms. I'm sorry, we're not in your network, right? And so it would seem that it should seem like the insurer, the payer, should somehow get that information to the patients to be like, hey, we don't have a neurosurgical service that's covered at this hospital, but of course that information isn't able to be disseminated, and you certainly can't expect patients when they're having an emergency to have this. So is there any onus on, before we talk about what you're going to talk about, is there any onus on the part of physicians and physician groups to kind of avoid this, to kind of to be aware of the fact that you're not in network and not send these type of bills to patients? After all, it just makes forgetting about the whole the altruistic part of it, it's just bad business, right?
Yeah.
It's just terrible PR.
It's interesting. So that's a great question. And really the term is surprise billing is a misnomer that's been propagated by the insurance industry in media already, right? It's not this is not a physician created problem. This is a insurance underpayment, keeping networks narrow, not being motivated enough to broaden their networks. This is what's really creating the issue. Even the term surprise billing, I don't agree with, but that's being used in the media right now, because insurers have, it's incredible how much lobbying power they have, how much media power, how much PR power. Someone thought about labeling this as surprise billing, in my opinion, because already the finger gets pointed at the physician about this problem. And we really looked at even premiums, and just look at the stock prices of some of the insurance companies and the CEO bonuses. They're not hurting. In the last 10 years since the ACA has been passed, and some of the loopholes have been placed into the ACA that have been crushing private practice, and have also allowed some of these insurer plans to have these clauses in them that allow them to cost shift everything to the patient and doctors, right? Instead of them paying fair rates.
It's very frustrating, because part of what the ACA did was the ACA, had a lot of mandates to say that you have to be able to deliver X, Y, and you have to have these plans that deliver pretty robust packages. Yet there's nothing in the ACA about saying, well, if you're going to say you're covered by this hospital, you're covered to go to this hospital, then there's nothing to say that you need to be in network amongst all these physicians. So it is really, really, really frustrating that this happens the way it does. But Daniel, it's still, the optics are still, the reason I think it has currency, the reason that the federal government is involved, the reason, California is doing what it's doing, and you're going to talk about that,
Yeah.
is that fundamentally what's happening is the physician is still sending a bill to a patient who's not a network. And by the way, the physician, the group, me, you, we know who's not at a network. So is there some onus, again, completely understanding the fact that this is a negotiation here between payer and whatever, and the patients we want to stick out of it. Why are we sending bills to patients out of network for 250 grand?
Sure. So I can't comment on really what happens from a inpatient emergency standpoint. I'm not really involved in that. I cover the ER to some degree. I have an elective practice mainly.
Right.
So I am out of network with some plans. Patients come and we make them fully aware that we are out of network before they kind of say, I want Dr. Choi to do my spinal surgery. So in those instances, I know that there is a balanced billing process. And in New York State, you're actually not legally, you are actually bound to balance bill. So to be honest, I'd rather not balance bill, right? I would rather just say, hey, we'll take whatever the insurer is going to pay for this. And the rest of this,
right off. Yeah.
I don't know a single doctor, honestly, that I know that wants to bankrupt their patient or put a lien on their home or anything like that. It's actually in New York State, you're required to. And actually there's been clawbacks and there have actually been lawsuits against physician groups that have not shown adequate evidence of balanced billing. Like if you did not, show that you sent letter after letter and you sent a collections agency against that patient and you were kind of trying to not balance bill, you would get penalized. So again, this is this weaponization of these clauses to try to keep us in network, discourage us. In New York State, they actually send checks. Like if you have an out-of-network surgery, they'll send that check not to the doctor, they'll send it to the patient. So the patient has to hand that check to the doctor, and it's completely unnecessary in my opinion. But it happens, and nobody wants to talk about it or bring it out of the open. I don't know if they're nervous about talking about it or they're nervous because they're out of network and but this is the only way physicians have to negotiate fair payments.
Right. So part of the problem is that the hospital is the one, so what folks don't maybe understand is that you do a procedure in the hospital, there's a professional fee and there's a technical fee. Usually the technical fee dwarfs the professional fee that you get paid for the procedure. So yes, you as a practice will generate a bill. That's usually a relatively small bill compared to the facility fee, the technical component from the hospital. And the hospital billing department, in masse will send out these massive bills. So it's one of these places where the physicians, even if they had a practice where they wouldn't send a bill, but because they did a surgery, the hospital billing departments, which are completely impervious to bad PR apparently, send out these massive bills. But then, the physicians, since they were the one that were in the hospital, folks don't separate out, the facility fee, technical fee. The physicians get, the brunt of the bad PR here. But and the other important point that you're bringing up here is, you primarily have an elective practice. You cover the ER sometimes, correct?
Yes, that's correct.
Yet this really affects you, correct? This doesn't because essentially by going after a surprise billing that in general comes out of emergent issues in the ER, right? Whoever is trying to basically put their finger on the scale on the side of the insurers by saying, all right, we are going to essentially control the rates of the providers. And as we all know, as we should know, if anyone listens to this show, is that when the government or when somebody who holds too much power on the payer side starts, putting their input in, the providers don't really have much of a say. Their physicians don't have much leverage at that point, and so they never get the price right. So a hospital, an academic hospital in Philadelphia called Hahnemann recently failed. It was in the news. Bernie Sanders came in. He was airdropped in to do something. And one of the big reasons why Hahnemann failed is because their population of payers was primarily Medicare and Medicaid.
Mm-hmm.
So as of right now, if we went to Medicare rates that are currently exist, and Medicaid rates that currently exist, if we just went to that, right,
Mm-hmm.
you know, there'd be a vast number of hospitals, a vast number of folks
Mm-hmm.
that would fail. And meaning that tells us that the rates that are being paid, certainly by Medicaid, and certainly by Medicare for a number of things, is probably under what the market should be. I mean, and so these large payers just don't get the prices right, which is why it's so important not to give up, not to be okay with the government saying, okay, we will set some rate. They won't get the price right.
No,
So,
no,
so
and
which is why
all services, not just healthcare.
right.
If you start, mandating rate setting. I mean, that's why that's been largely avoided in America for many industries. Every industry, I think, we consider ourselves to be a free market, and
Right.
this is why for some reason the economists love arguing that healthcare shouldn't be a free market, but that doesn't make sense.
Right. So New York, that's why, and this is why the New York rule, the New York law, which basically allows for independent arbitration between the insurance company and the doctor, leaving the patient out of it, is such an attractive option. Now, California has its own ideas, and unfortunately, it seems like the federal government is leaning towards, or at least there seems to be a lot of popular support for what California has done. Can you talk a little bit about what California has done in terms of benchmark?
Yeah, absolutely. And when it all comes down to it, I think what you've really touched on here is this is not a surprise billing issue. This is when it comes down to it, it's actually a Trojan horse. It's a complete restructuring of the payment system. That's what they want to do. They just want to completely restructure the payment system using this legislation, which is why it scared the crap out of me when we got starting at the beginning talking about how I got so interested. When I really uncovered the legislation, I was like, this isn't just going to affect the ER practice or practice. This is going to affect in-network physicians first. And that's what everyone has shown. And that's what's happened in California, actually. So what they did in California is that in 2016, I believe, they enacted a law that was a rate-setting law, and it implemented benchmarking. And they set all out-of-network payments as a percentage of in-network rates, or some average of in-network rates. And so what that all of a sudden led to is the insurers are saying, okay, we got this law passed and we have a benchmark now. Now we just need to make sure. So if we want to pay the out-of-network people less, we've got to take the in-network rates and drive them down lower. So the California Medical Association said that, immediately, like the day after this law was passed, contracts that have been in place for 30 to 40 years with hospital hospital physicians, they were torn up. The contracts were torn up overnight. And they said, you know what? We want to pay you 40% less for all your services. We're going to take a 40% cut. Anthem was one of the first in California to do this. And what happened? Well, the doctors were like, you can't do that to us. The insurers said, sure we can. If you don't like it, go out of network. There is no fear at that point for physicians to go out of network. They said, okay, go out of network. We'll just pay you maybe slightly more than this 40%, rate decrease. And you can't do anything about it because the law says that's what's legal now. So that completely devastated physicians in California from my understanding. And unfortunately, we don't really have the best data. Physicians, especially in the private sector, private practice, this is something that we definitely need to do more of, is we need to pull more of our data. And some of this is, I don't know if we can't share data because of antitrust laws. We can't talk about our rates, right? Because we are not allowed to collectively bargain, which is another ridiculous topic for another podcast, I'm sure. But we don't have good data to back up even what I'm saying right now, except anecdotally from the California Medical Association. And then if you look at the managed care reports, I actually did some digging and I looked into their reports, and since 2016 it was like 300 something access to care complaints to the managed care department. And then 2 years later, it was like 520, and it almost doubled in the number of complaints. So just looking at that trend, access problems have been tremendous in California, and especially rural care. Think about like rural hospitals and rural EDs that are already operating on very razor thin margins. They were hit the hardest in California.
Right. What it basically kind of leads to, ultimately, I think ultimately it's a little bit of a self-own, I think, because what happens is providers in response consolidate, right? Because they need leverage when they in order to negotiate. And so you end up with consolidation, and that consolidation is with hospitals.
Yep.
And hospital systems negotiate rates that are way higher, I think, in general, than what
Yes.
a private, say a specialty hospital that you and your group were able to somehow
Mm-hmm.
get. I bet you'd be able to be much more efficient there than you were in the certainly in local academic teaching hospital, which is incredibly inefficient and has
Sure.
seven clinical documenters for every physician, and 12 scribes and
Yeah.
whatever it is they do. And so that makes their rates super high.
Yeah.
So I think ultimately it's a bad move, because yes, the fundamental problem we can't forget about is that this is all happening because the healthcare system is costing Americans too much. We're at a point now, whether you look at percentage of total GDP or you look at percentage of income that is going towards healthcare premiums, that there's a desire and a need, both on the left and the Democrats and the Republicans, to devalue what we pay. To pay less for healthcare.
Yep.
The problem is that as physicians, I think the right way to play is to be on the side of that, on the side of lowering how much we pay for healthcare.
Sure.
But at the same time, the trickiest thing for us, because we're the labor that delivers healthcare, is to not devalue us in the process of doing
Absolutely.
that.
Absolutely.
And the way to do that is really, is really to stimulate competition,
Yes.
so that we can work more efficiently, we can be more productive,
Yes.
and thereby allow a remuneration that makes sense for a highly trained spine surgeon, right? So that when mom or dad or me shows up in extremis in the ER, there's somebody that's very good who's waiting to take me to the hospital. Versus, if you cut rates for a spine surgeon, say in half, you start paying Medicaid rates or Medicare rates. I really think that the quality of folks that you're gonna get, this isn't said enough, I think, but the quality of folks you're gonna get into those areas is going to be is going to really suffer. And remember, it's not just competing within medicine, right? Now, already we're seeing, if you can go into finance and make six figures starting at the age of 32, and not be on call at 10 p.m. to come in and deal with some 75-year-old who has an intracranial bleed. This is stuff that there's a reason we value our physicians so much, and I think people are losing sight of that. But the way, and I think you're doing the right thing, Daniel, in terms of trying to raise the point over and over again that this is a battle that isn't about patients. It's a battle between insurers and physicians, and we don't want people putting their finger on the scale of insurers, because that could certainly harm doctors when we're making these contracts. Now, there's a lot of data that is thrown at us. There's a lot of stuff that's written by folks in the in health policy, right? And so so some of the folks, the Brookings Institute, for instance, you've done a little bit of digging tell me a little bit about the Brookings Institute and what they say, and what you found out.
This, for me, I'm not a health policy guru, or it's not even like an interest of mine, to be honest. I spent like the last 7 years in a black hole. Like, I was learning orthopedics. I cared about hip fractures and laminectomy. Like, this is the stuff I was in a black hole training, and all of a sudden, in the last 4 months, I've gotten this crash course on healthcare costs and all these administrator versus physician graphs. And it's interesting. All I could tell is that these health policy experts were never in touch with what you and I see on a regular day basis in the clinic, right? And if you kind of cut to the chase of all the arguments they're making, and what should concern physicians is that these economists and health policy experts have direct links to the Congressional Budget Office, CBO. CBO scores bills, and that ends up what gets legislated. And so literally, those economists have a say in what bills will pass Congress. And then you have the whole slew of health policy economists. If you really cut it, they have a lot of fancy terms and fancy studies, and all those studies are with data that's provided by insurers, right? If you really cut down to it, what they're saying is they're devaluing physicians. They're saying that we pay physicians too much. We should not allow any charges. Charge data should not be allowed, and they need to be set right and fixed to Medicare rates. That's their MO. They think that if we do that, then we will solve healthcare costs in America. Never mind that the insurers are making millions and billions and billions of dollars, or whatever the CEOs are taking home millions and millions. Never mind all of that. Just blame the physicians. Make sure that they can't charge more than a certain amount, and then we'll solve healthcare. And they're not thinking about it in a broader spectrum. And then I did some digging about the Brookings Institute. And look, I can't provide a direct link, but all I found was that recently that the Schaefer Institute of Health Policy, which is the main arm of Brookings that does health policy, they have a pledged $25 million donation from a former WellPoint CEO, which is Mr. Schaefer. He is a former WellPoint CEO. So look, I'm not saying that they're writing studies like the way he wants it to, but they're heavily funded by the insurance industry. And then they're coming out with study after study after study from insurer provided data. And as physicians, we all know about selection bias is you can find any conclusion you want if you have preconceived notions about how the healthcare system should be fixed. And, these are, and again, I can't speak, this is all theory, but, I think a lot of these health policy economists are also kind of the ones that were part of the design of the ACA initially, that really tried to drive private practitioners out of business because they thought that we were the cost drivers of the system. So, that's what I have to say about that.
Yeah, no, there's certainly a pre-existing bias that exists, and it's been interesting to watch just over the last 8 to 10 years. Just a small story to tag on to what you were saying, that initially Dr. Gawande, wonderful writer, wonderful books that he writes. He of course wrote, started writing about health policy and what was wrong with the American healthcare system. And he comes out of the academic system. I think he was at the Brigham, or he's still at the Brigham, still has an appointment there. And so his take on what was wrong with the healthcare system was very much that the problem was the private practice way of doing things, because it was a fee for service model where we it was all about volume. And so he did these exposés in McAllen, Texas, where he went down and said, look, you have all these folks that are essentially trying to induce demand, right? They're setting up all these stress shops in shopping centers and driving, and everyone gets a stress test once a year, et cetera. So it was easy to see, and there's certainly abuse in that form, in that place. And he interestingly he relied heavily on data from the Dartmouth Institute. The Dartmouth Institute put out data showing how much different the utilization of Medicare dollars were in places like McAllen, Texas, versus places like Mayo, right? Mayo is the academic, everyone's salaried, and he writes very nicely about how he would go to Mayo and a cardiologist would appear to do a preoperative risk stratification, and nobody was billing anything, and it was unbelievable, and it was wonderful. And I remember reading that I remember reading that when I was a fellow and being like, oh my God, this is amazing. Yes, we all should be like
Yep.
Mayo.
Yep.
And
Yep.
freaking people in McAllen, Texas are like
Yep.
going nuts, right?
Yep.
And then I got into practice.
Yep.
I was like, how the heck does anyone pay for that? I don't understand that. How are they producing these cardiologists who at the drop of a hat would just show up in a surgeon's clinic 2 floors down and just see the patient? Amazing service for the patient, by the way. So it's awesome. And then there's another set of data that came out 3 or 4 or 5 years later from the Healthcare Cost Institute, which is HCCI, which is essentially a bunch of private commercial payers, the big ones, I think IBC, Aetna or something, and a bunch of other folks who basically came together and accumulated all their data in a database in terms of how much they were paying across the country. So essentially you had 2 parallel databases. The folks in Dartmouth had all the Medicare data in terms of how much they were paying and how many procedures were being done. And then you had the HCCI, which had all the commercial info, right? And all the places where Medicare looked, where it looked like Medicare was being fleeced, basically McAllen, Texas, whereas everything was going beautifully in Minnesota, and they weren't doing, when they looked at how many stress tests per X population, Minnesota looked amazing. And it's like, look, this is why we have to be like Minnesota. But then when you looked at the HCCI data, which was the commercial payer data, you now figured out why Mayo was able to do what they were able to do. The amount that they were charged to commercial insurers per unit of healthcare widget delivered was like multiples of that being delivered in McAllen, Texas. So basically, Mayo, there was no magic there. It was just that they were saying, okay, Medicare is great, but since we are the only game in town, which is what Mayo is. I mean, how can you be an insurance company in Minnesota and not include Mayo? Like, what patient would be like, okay, let me sign up for this plan?
Yeah.
They have a ton of power to negotiate with commercial insurers.
Yeah.
So it's this. I don't think people have a sense that it's this battle between these large, big players, and they are huge, they are big, they're organized, and they're unified, right? So the commercial payers, there's 4 or 5 big guys, and they are unified. They have a lobby. The hospitals are massive. Hospital systems are $5 billion per year enterprises. There's like 4 or 5 of them in major cities. They are also organized. They also have a major lobby. You know who's not organized and unified? It's doctors. It's the ones who actually deliver all the. I mean, we are the widgets that actually sit there. An hour ago I was in some ICU doing some ultrasound. And we are completely fractured and not unified at all. And we have been, unfortunately, most of our professional organizations, there are some notable exceptions, most of the professional organizations have just let us out to dry because their leaders, unfortunately, just kowtow to the status quo. So I'm really hopeful, Daniel, that I think you're and I'm old enough now that you're the younger generation.
I don't know about that.
can hopefully provide a ray of hope here, and through your advocacy, which is wonderful on Twitter. Your Twitter handle is
at Dr. Dan Choi, at Dr. Dan Choi.
Yes. So he's
pretty vocal on there.
Yeah, no, he's fantastic to follow on there. So I'd urge everyone to go out there and follow him and hopefully kind of get involved. You've done an amazing job in terms of, there's a nice tweet thread of yours that I saw where you kind of bugged congressmen multiple times and finally got to speak to somebody, and you actually, I'm kind of jaded, but you actually, met with them and perhaps are having some positive influence, and it goes to show how much advocacy can actually do. So great work, Daniel. Any I know you're super busy, but anything else you want to add?
I mean, I could probably talk for hours.
Yeah.
I think that if you're listening to this and you've made it through all the esoteric stuff I was kind of blasting you with before, if you're here listening to this, I really encourage every doctor out there to there's a lot of hands up in the air saying we can't do this, and there's that we're so unorganized, and it's a lost cause. And I got to tell you, learning about all the processes now, I've kind of felt that. I've felt that hopelessness at times. Like, wow, like Everyone else is so much better organized than us. They're well funded than us. But I think what my hope is, and my hope in the graduating millennial doctors, is that millennial doctors also care deeply about advocacy. Like, I'm not the only one out there talking about policy or issues or burnout, doctor burnout. We also have the power of social media, and we can connect. The reason why you and I are connecting, and now you're amplifying this message to other physicians, is strictly due to social media. Is that I hope that, look, me screaming about this on Twitter is not going to matter. It's not like, nobody cares. Like, yeah, I'm trolling some economists I'm not really trolling, to be honest. I'm not trolling them. I'm giving the physician defense to their arguments, right? And they're rational defenses on Twitter. They don't like it, but they're our perspective. But me doing that, honestly, at the end of the day, is probably not going to do anything. It's not going to change the conversation. I encourage every one of us, no matter how jaded you are, you've got to get back to your professional organizations. If we're not happy with the AMA and what they're talking about, they have a delegate system. And yeah, you're going to move the needle. But my mentors in Medical State Society in New York, who has been very active on this issue of surprise billing, they were ones who were very active in passing this bill 5 years ago. They have an effective lobby arm. They're full of private practice physicians as well as employed too. But it's not too late for physicians to get involved. We were able to recruit 9 to 10 physicians, to come to these congressional meetings here in New York, and it moved the needle a little bit. And yeah, what's hard is that when we bring 9 to 10 physicians into that room, I looked around and I was like, oh my God, there's probably like 500 patients today that are not being seen because we're doing this meeting. But when it comes to political engagement and organizing, it's not too late, and we can use every single one of you who are on here. So my encouragement or call to action would be, call up your local medical society. Start with your county. Every county has their own medical society. And if you're not happy, you walk in the room and you hate it and you don't see eye to eye with anyone in that room, try your state specialty society, your orthopedic society, your cardiology society. And if maybe you're like the one of like 4 people who care about anything in the state, but guess what? Your disgruntlement and your anger, which is what I have a lot of already in the first couple of years of practice, can translate into a collective voice with other people. And that's the only way you're going to bring about some type of needle pushing. So that's my encouragement. And that's, what I'm on fire about, of trying to get people engaged with their medical societies.
Daniel, fantastic stuff. I know you have children and a wife to get back to. So thanks again for taking the time. And we'll see you on Twitter. All right.
Thanks. Thank you so much. Okay.
Thanks
have a good
again.
night.
Yep.